Our topic for this session is aortic trauma. Our first case, an aortic isthmus laceration. You see it here, this irregular contour abnormality in the isthmus region right at the juncture of the posterior aortic arch and descending thoracic aorta. This, of course, is the most common location for a blunt trauma aortic laceration. Note the relative lack of periaortic or mediastinal density, which can be an important indicator of large vessel injury, but which is not universally present, and which, of course, will not be confused with this anterior triangular lobulated density, which I'm sure we all recognize as normal thymus. In the abdomen, this patient has peripheral wedge-shaped, well-circumscribed hypodensities in her spleen, consistent with thromboembolic infarcts. That, in turn, in the setting of trauma, is suggestive of an upstream large vessel injury. Note the significant absence of perisplenic fluid. On the sagittal, we see the telltale intimal flap of an aortic laceration, and anterior to it, a small outpouching of contrast representing a pseudoaneurysm bound by adventitia. There is the abnormal contour of the aorta. Here in the abdomen, the splenic hypodensities. And on the sagittal, the intimal flap. It is important to distinguish these injuries from a normal ductus bump or a persistent ductus arteriosus. This is the latter. You can see that small systolic spurt of arterial contrast in the pulmonary artery. In comparing a ductus bump to an aortic laceration, note that the ductus bump is more anterior and superior in location, is more transversely oriented, and forms a more shallow angle with the distal aorta. And there again is the intimal flap. This patient had a 1-week follow-up scan on which you see that pseudoaneurysm is now much better circumscribed. There has been resolution of the splenic hypodensities, also consistent with those having been thromboembolic infarcts. On the sagittal, you see the well-circumscribed, narrow-based pseudoaneurysm and interval healing of that intimal flap. There is the tiny contour abnormality on a 3D, and here it is on the axials and the sagittals. So obviously, this patient survived this aortic isthmus laceration. Our next case is of an aortic isthmus transection, an injury in the same location, but obviously greater extent. You see here mediastinal density and the proximal defect in the aorta. On the next cut, you see an intervening segment of dilated aorta, which represents a pseudoaneurysm bound by adventitia. And on the next level, we see the distal aspect of the torn aorta. This patient also has a hypodense right kidney with an absent arterial nephrogram in comparison to the visualized left kidney. The presence of contrast backflow in the inferior vena cava suggests that the right renal venous backflow is physiologic rather than being related to an arteriovenous fistula. In either case, there is clearly an avulsion of the right renal artery that is not visualized. There is the intervening segment of dilation, and you see the two torn ends of the aorta, proximally and distally. In the abdomen, there is right suprarenal, IVC, and right renal contrast backflow, and again note the asymmetry of the nephrograms. On the 3D, it becomes quite clear the nature of this injury, a complete tear through the aorta with retraction of the torn ends. You see it nicely there on the 3D. This is a magnified T-spine study very nicely showing again the retracted torn ends with an intervening segment of dilation. So that is an aortic isthmus transection, obviously with an associated right renal artery avulsion. Our next case is a laceration of the aortic arch. These are perhaps the most difficult aortic lacerations to spot here on the undersurface of the arch. They can be very small and frequently are present only on a single image, even on thin section studies. Again, you note the mediastinal density, which hopefully would call your attention to this injury, and note also the extensive spinal injuries, including a disrupted spinal column and active contrast extravasation within the spinal canal. On the next cut down, you see again the mediastinal density and the complete disruption of the spinal column. The lungs are extensively injured as well, with consolidation of the dependent lung, ground glass density of the aerated lungs, and small anterior pneumothoraces. These lacerations can even be difficult to spot on reformatted images, but there it is, that tiny focus of contrast extravasation and the associated mediastinal density. On the 3D, this makes for a very small focal contour abnormality. And there it went. Don't blink or you miss these. Very small focus of extravasation there on the undersurface of the arch. Disrupted spinal column, and note the costovertebral dislocations. I've come to take that as an indicator of a very serious injury. And again, the extensive lung injuries with consolidation, ground glass density, and small anterior pneumothoraces. And there it is on the 3D. Probably worth looking at again, that tiny focal contour abnormality. And so that is a laceration of the aortic arch. This patient did not survive, but the physiologic parameters suggest that he actually died of neurogenic shock and not as a result of the aortic laceration. Our next case is of an ascending aortic laceration. You see it here, contrast extravasation on the anterior aspect of the ascending aorta with adjacent mediastinal density. In addition, there are multiple rib fractures, there is pronounced volume loss and consolidation of the right lung, there is fluid within the bronchus intermedius, and you see the tip of an endotracheal tube in the left mainstem bronchus. Let's look first at the ascending aortic laceration. There is the contrast material on its anterior aspect. You can see emanating from that defect in the anterior wall. It is important to distinguish that extraluminal contrast material from the adjacent motion artifact and right atrial contrast, which you would not want to confuse for this aortic laceration. Let's also look at the left mainstem bronchus intubation. When I first saw that, I thought it must be in error, but then I realized with that fluid in the bronchus intermedius and the extensive injury to the right lung, this was actually a very intelligent move on the part of the emergency room physician. By performing a left mainstem bronchus intubation, he jailed the right bronchial system, preventing hemorrhage within those bronchi from getting into the left bronchial system and protecting the damaged right lung from barotrauma. So a very intelligent move that no doubt contributed in large part to this patient's ultimate survival. And that is a case of an ascending aortic laceration. Our next case is another ascending aortic laceration, this one a penetrating trauma. There is anterior extrathoracic soft tissue gas, and note the wisp of extraluminal contrast emanating from the anterior wall of the ascending aorta. Lower down there is a large hyperdense or at least isodense pericardial fluid collection consistent with a hemopericardium. Note also the compression of the ventricles and dilation of the IVC consistent with tamponade physiology. On lung windows, there is extrathoracic gas and a small hemopneumothorax, but also note this linear tract left by the stabbing. It is an important principle in penetrating trauma that you not simply lay a ruler along the path of penetrating trauma and expect all injuries to be restricted to that path. This particular case is an excellent example of that. Again, you see the ascending aortic defect right there on the anterior wall and really quite distant from the path suggested by the stab wound. Obviously, the patient was tachycardic, possibly in a different position, and that resulted in the ascending arch injury. Note here again the large hemopericardium and tamponade physiology. And there again is the linear tract, which might just mislead you. So that is a penetrating laceration of the ascending aorta. This patient did survive. In fact, they had him in and out of surgery so quickly that I read his post-operative plain film that same night. Our next case is of a descending aortic laceration at the diaphragmatic hiatus. Even on soft tissue windows, you can see the rib fractures and extrathoracic gas, consistent with the presence of a pneumothorax. There is an ill-defined hypodensity in the right liver lobe, consistent with contusion or laceration. But the important finding here is this semilunar contrast collection within the wall of the aorta, consistent with a contained laceration. Note also the significant retrocrural stranding. On the video, you'll see significant wall thickening throughout the descending aorta, consistent with intramural hematoma. And here is that semilunar contrast collection, consistent with contained laceration. This was managed with observation, and unfortunately this laceration let loose the following morning, and this patient did die of hemodynamic shock and extravasation. So an unfortunate case of a descending aortic laceration. Our next case is an aortopulmonary fistula arising from a left lateral arch laceration. You see there is a pseudoaneurysm with a small focus of air consistent with an aortopulmonary fistula and suggesting the associated laceration of both visceral and parietal pleural layers. On the lung windows, we see directional density within the pulmonary parenchyma consistent with a contusion. And the video helps us appreciate that laceration on the lateral aspect of the aortic arch, a contained pseudoaneurysm limited by compressed pulmonary parenchyma and containing a small focus of gas diagnostic of aortopulmonary fistula. And again, the contusion of the pulmonary parenchyma. So that is an unusual lateral arch laceration with an associated aortopulmonary fistula. This patient did survive. Our last case is a BB or bullet embolism. You see here a tract of gas in the left pectoral region, which again, by its linear course, would actually mislead and distract you from this mediastinal stranding, which clearly requires explanation. And lastly, this tiny intimal flap on the posterior aspect of the aortic arch. The whole body scout film is what brought this whole case together, though. You can see a rounded metallic density in the patient's calf, consistent with a BB most likely located in a branch of the posterior tibial artery. So you can see what happened. The BB passed through the pectoral region, entered the anterior aspect of the aortic arch, causing this mediastinal stranding, and ultimately lifted an intimal flap from the posterior aspect of the aortic arch. A pinhole defect was found in the anterior arch at surgery, as was that intimal flap. The calf foreign body may lie there to this day. So that is a case of BB or bullet embolism. And that concludes this session on aortic trauma.